Good day, first and second year physiotherapy students. It is great that you've joined me for our lesson, Gait and Mobility Aids. My name is Monique Kadler, and I will be guiding you through this topic. The content that we will interrogate and that you will learn and experience in today's lecture will answer the following question: why patients use mobility aids? Why do you think they need mobility aids? Let your mind wander and think of a period in your life or the lives of your family and friends where they walked with crutches or a walker or a walking stick, a cane, just to name a few. And think, why did they need that at that point in their lives? After that, we will look at factors influencing selection of the mobility aid. What mobility aid will be best suited for them individually? Because one mobility aid doesn't suit everyone. So you have to take these factors into consideration. We will thereafter go into two concepts: the base of support, how big the base of support is you are standing on, and where is a person's center of gravity at certain points in time when they move, when they shift weight. Following that, we will go through preambulation. You might want to ask yourself, but what is preambulation? We will look at that and go through a systematic way that you can incorporate this into your therapy to ultimately ensure that the patients are safe and that they are ready to walk with the mobility aid. A very useful tool where the preambulation starts off in is often where there is a parallel bar. That may mean that you will have to move your patient in a wheelchair to the gym in a hospital or a care center where the parallel bar is. Some wards have them in a rehabilitation ward as well. Depends on the setting that you are in. But very useful, parallel bars give support for walking again before moving on to the mobility aid. Thereafter, I'll briefly introduce you and we will have a quick look at the types of mobility aids. These on the slide, but not only these. So sit forward in your chair, give me your full attention, and let's go through these topics. So why do you think patients use mobility aids? It is ultimately when their gait, when their walking is impaired. Different reasons that can happen. Of course, can be after a stroke, after a knee operation, after a hip replacement, after a sprained ankle, sometimes to just help them heal up. Sometimes then patients are not allowed to put weight on a limb at all after an ankle fracture, depending on the individual medical condition. The following are some of the reasons why walking aids are required. Number 1, to assist with weight bearing. There are 3 different weight bearing statuses. 1, non-weight bearing, where they are not allowed to put any weight on the affected leg. Next, 2, partial weight bearing, where some of the weight of that injured limb can be placed on the ground. Often as pain is tolerated, you will have to make this point very clear. Thirdly, full weight bearing. When your doctor tells you mobilize this patient full weight bearing, it means that the crutches are simply there to support, for balance, but that then, if full weight bearing is allowed, there is no concern that the injured leg will be injured more if weight is placed on it. That is weight bearing. Balance, number 2. At times, it is simply the balance of the patient that is not sufficient to walk without a mobility aid. Then that will help them. Number 3, to improve their motor pattern. I'm sure you've seen some people walking in the mall and you can clearly see the limp, and that you are then concerned about their back or their hip or the joint above, below, that will take more of the strain and load will be transferred to another area. And you can clearly see that the motor pattern of the gait is not correct. Well, if you place a mobility aid in their hands, then they have an external aid for them to allow to reduce the pain in that amount that they can actually improve their motor pattern. So you may want to tell somebody, you know what, for a few days you will need crutches just that we can improve your gait pattern while your ankle is recovering. Always remember individual preference and what you need for that patient. Number 4, it is often after an operation that they lack confidence, or even in our older population where they are fearful of falling. A walking frame will give them some confidence and will allow you to get out of the bed and improve your circulation through mobility, and that will prevent complications of bed rest. So all of that by giving them a bit of confidence when you add a mobility aid. Number 5, endurance. They will be able to walk further with the mobility aid than what they might do without one. And that is some of the reasons why patients use mobility aids. So what factors influence our selection as physiotherapists of the correct mobility aid? Age. The elderly need more stability. Even more stability than, for example, an 18-year-old schoolboy who has sprained his ankle. You will surely not give him a walking frame, will you? For him, rather crutches compared to a fearful elderly person that might need a bigger base of support, more stability. So age matters here. Strength. What is the upper limb strength? Is it good enough? Is it strong enough? Grade 4 to 5 Oxford to be able to handle crutches. Have you tried walking with crutches yourself? You will find that you need more upper limb strength for that. Balance. A factor that influences the selection of a mobility aid. For a lady that's very fearful after a knee replacement, crutches will not give her the balance that she might need initially. For day one, you mobilize her, get her out of the bed. A walking frame will help her balance. As you then improve, you can always change to a pair of crutches. Complications. This is where, for instance, if there are multiple injuries, a lower limb fracture with an upper limb fracture, where there's not load or weight allowed through the upper limb. So to walk with normal crutches or a walking frame is not allowed. What then? What do? We have a very useful walking aid named gutter crutches. That allows the elbow to be bent to 90 degrees and weight is placed on through a shorter lever of your elbow. You'll see a little bit later when I show you the mobility aid types. But that complications is also an influencing factor. Patients' needs. So this includes economic need. Can they afford it? Do they have one crutch and you just need one more? Do they have stairs at home? Because have you ever tried climbing stairs with a walking frame? Not easy and not possible, right? If you want to climb stairs and you've issued a walking frame to your patient, they will need to hold onto the rail and have another supporting person on the opposite side of the rail to help them up the stairs. Crutches are way easier to climb stairs with, up and down. Then there's the factor of space. How much space do they have to maneuver and walk through? How much space is there in a taxi they use as transport? All these factors influences the selection of the mobility aid. Let's consider the following terminology. Base of support. Base of support refers to the area below or beneath a person or an object. That includes every point of contact that the object or the person makes with the supporting surface. So if you think of standing, then it will be the point beneath the 2 feet, each point in contact with the floor. Think about somebody on all fours. Now it's not just the feet, but now it's on hands as well. So that is then a larger base of support. Now with mobility aids, let's consider if you issue crutches. then you have a similar 4-point base of support as compared to the same as with being on all fours with rehabilitation. But consider how the base of support increases when you add a walking frame. Now it is not only 4 points of contact with the ground, but it is 6. You see how the base of support can be enlarged to give confidence, balance, and safety for somebody that requires that. Center of gravity, per definition, is a point at which the entire weight of the body may be considered and concentrated so that if supported at this point, the body would remain in equilibrium in any position. So if you move standing up, let's try it. Stand up. Now, as you move, as you stand still, your center of gravity is through the middle of your body. As you take a step forward, it shifts. Center of gravity shifts. So, to conclude on base of support and center of gravity, in a standing position upright, the base of support is small with high center of gravity on one point, requiring greater support. Standing activities are most often initiated for that reason in parallel bars. That is the reason why it is often a challenge to stand up and just start walking. But a walking frame will have a wide enough support compared to crutches or a simple walking stick. But maybe it's just a walking stick or a cane that your patient need to move around with. And then that is sufficient for your patient. Here are some images, some pictures to show you how the base of support changes. Take a look at the left top picture, shows you your base of support, and your CG, your center of gravity, and how the base of support changes with putting one leg forward and adding crutches. You'll see that the crutches under his arms that he is using in the picture, left at the top position is auxiliary crutches. You see that it fits snugly under his axilla. At times you will still find them in the hospitals. Not that often can you see that with the auxiliary pieces under the armpits, that can cause, if somebody hangs on these crutches forward and rests on it, that it can give a neuropraxia of your upper limb nerves. You see that? So always give correct advice and precautions with somebody if they are mobilizing with auxiliary crutches. Some patients love them. Some patients often ask for them. It almost feels like they are more stable with them. But you have to walk correctly with them. Picture on the right to the top shows us the change in center of gravity. Can you see that? Where the center of gravity is inside, safe position in A. B, the person, it looks like they're shifting weight to their right, our left. And number C, the center of gravity is moving outside the base of support, and it looks like they are going to fall. Always be close to your patient when they walk with their mobility aids. Be sure to do the following 3 things before you allow them, just as a guide to walk with their mobility aid. Communicate to them, number 1, communicate to them the precautions they need to take. Make sure you have implemented the precautions of removing socks, making sure the surface is not wet or slippery. Make sure the mobility aid is good to walk with and safe to walk with. Number 2, practically demonstrate to them how to walk. 2.5, make sure it fits them correctly. Adjust the mobility aid to the correct height for the individual patient. It's not a one-size-fits-all. You have to adjust it. And finally, number 3 on this point is be close to them when they start. Be sure to put the chair close and ready before you ask them to stand up for safety. When they start walking, be on their side and slightly to the back. Be sure to be very close to make sure they walk safely. Picture at the bottom shows you the stability as you move your legs apart. All right. So what is preambulation? And what does it entail? After this, you will be able to, in theory, understand how, even before putting the mobility aid in their hands, in your patient's hands, how you can rehabilitate in a way to make sure they are stronger, safer, more confident. Before a walking activity, they may require a pre-ambulation rehabilitation program that we are now talking about. Before you can walk, they will need good balance in standing. That's one of the things pre-ambulation rehabilitation will teach them. Before they stand, they need to be independent and have a good balance in sitting. A very important point is that you have to test their sitting balance as well as their standing balance before placing mobility aids in their hands. You have to be sure that the balance is sufficient, or else you go and do this rehabilitation program. Before they sit, they need to be independent in bed. So it's that progression of activities. If they are independent in rolling in bed, moving up, lying to sitting, sitting over the side of the bed, then only can you sit. If they have good sitting balance, sufficient and strong and not dizzy, can you then allow them to stand up? If they have good, adequate standing balance, can shift, transfer weight, reach forward, you add rhythmic stabilization, and they're not falling over in standing, then you can let them walk. Then the patient needs to overcome the orthostatic postural hypotension before they can walk. If they've been in bed for prolonged periods, when you sit them up, they will be dizzy, often pale, they say they don't feel so well. That is orthostatic postural hypotension. Always be sure to check the vitals, the vital trends in the file, but also to measure the vitals before you get them up and moving with the mobility aid. So picture this, parallel bars, 2 bars that you can hold on. Now you've brought your patient with the wheelchair from their room to the gym where the parallel bars are. Now you are wheeling the wheelchair closer to the parallel bars, almost just next to them. You are now adjusting the parallel bar height. This will almost be a guesstimate, but many of these parallel bars are set to the norm height of people. But when you see that, when you stand in the parallel bars yourself and you see, but this is so high or very low, and you know how high the patient was when they stood next to you at the bed, then that is a useful measurement that you can use to adjust the parallel bars. So now, in an upright position, you've measured that there's adequate motor control. So now we start with our pre-standing exercises in the parallel bars. A good measurement is to adjust the parallel bars to allow 20 to 30 degrees of elbow flexion, a slight flexion, and come to about the level of their great trochanter. A good height. And you will see these measurements when we measure the mobility aids to the correct height for your individual patient. So now that the wheelchair is on the one side, be sure that there's a chair on the other side of the parallel bars. Lock the brakes of the wheelchair. Footrests are folded up and placed upright and to the side. Make sure the patient's feet are flat on the ground before you commence the preambulation. 2 pictures showing you what parallel bars look like if you have not seen them before. So let's now sequence, and in your mind picture you and the patient now going to do these preambulation activities. Remember, firstly, you give the initial instructions. Show them what they need to do. Tell them, show them, and let them do it. So demonstrate. Let them stand. In standing in the parallel bars, do balance movements. Check their balance, side to side, forward and backwards. Do some rhythmic stabilization for their balance. You can also add, like we said, lateral weight shifting, the side to side, anterior posterior weight shifting. You can also use a band placement around you and around the patient to guide them if their balance is not sufficient. Or a single band support, progressing to no band as they get better. So this is now you rehabilitating your patient to allow them to hopefully mobilize with a walking aid in the future. In that standing position, you can hip hike. Be sure as you listen to this, stand up and hip hike, move your hip up on the one side while you are shifting weight. Standing push-ups with your arms on the parallel bars. very good for upper limb strength. Then allow them to step forward with one foot and back with one foot. Be sure to respect the weight-bearing status here. If they're not allowed to put weight on the leg, surely you can't put weight on that leg. Now we progress to moving the next leg forward and the next leg. You are close to them, often behind them, or just at the side of the parallel bar where it is the safest for you to position your body. Always good to be just behind and to the side. As you move forward walking now, there will come a time at the end of the parallel bars where they will need to turn. This can be quite risky, so make sure that they take small steps on the spot, that they don't pivot only on one leg. Be sure to adhere to your precautions and contraindications, especially when it comes to replacements. From there on, they return to the seated position, either on the chair or back in their wheelchair, depending on their endurance. You now measured the time that they've been walking, or you've measured the steps, or you've gone once to the chair and back. You can even measure that in meters walked. As a progression and advancement of the activities in the parallel bars, you can add resistance to forward progression. That means that you actually hold their shoulders slightly back as they move and walk forward. You can ask them to do the following, which is also an advanced parallel bar activity: walking backwards, walking sideways, or a side step. You can add your PNF, thoracic, trunk, or arm, if they're very stable, leg PNF patterns, even in the parallel bars. The only limit to how you advance these activities is your own creativity. Be creative. Use TheraBands, but always suitable for your patient. Now for the mobility aids that you will walk with. A few examples. In the top left corner, you will see a cane, a quadrupod. Sometimes there's only 3 pieces of steel touching the floor. But in these, you will see that there's 4. Can you tell me, what do you think, why will we issue a quadrupod for somebody compared to just a normal walking stick or a cane? Can you answer that? Why don't you write it down and tell me? Be sure to list base of support, center of gravity, and examples of injuries and conditions where you will rather prescribe a quadrupod for your patient. Next to it on the right side is a walking stick. I'm sure you've seen that some of your grandparents or family members, even in your community. People are often very fond of their walking sticks and have all kinds of decoration and special wood, very handy. At the bottom of the cane or the walking stick, you will see the rubber casing. that needs to be intact. After many years, you will see that it wears and that it can become slippery. Often the crutch can break through it. Be sure that that is intact for safety. Right top corner is a pair of auxiliary crutches. Metal and not wood are those. Now we move to the left bottom corner. And this, do you remember I told you when there's complications, when there's a fracture of the upper limb, a gutter crutch is often used. So take a look at the hand piece where it sits almost in an upright position compared to a crutch where it's more horizontal. It is because you will put your hand and forearm in and grab onto that gutter crutch. To the right, one of the most well-known mobility aids is the humble crutch. Right to that is a walking frame. Take a look at that big base of support compared to the single crutch, or even two crutches. And the last one on the screen, and that I want to show you for today, is the walking frame with wheels on. This helps momentum. It's often when they can't lift up, when they don't have the balance and the strength and the weight shift to lift up the walking frame. This allows them to just simply slide it and move it forward and makes life easier for them. This is definitely not an exhaustive mobility aid types. There are many more that we will cover in the next lesson. So to wrap up, what did you learn in this session? You learned about factors influencing mobility aids, why we use mobility aids, why we prescribe it for our patients, and then we looked at base of support, center of gravity, parallel bars, pre-ambulation program as a rehabilitation, and the mobility aids. Please catch the next lecture and see you soon.